This 12-year-old male presents with a classic triad seen in pediatric nephrology: acute glomerulonephritis, AGN, cardiomegaly, and pulmonary edema. On this AP chest radiograph, the cardiac silhouette is markedly enlarged, with a cardiothoracic ratio exceeding 0.5, indicative of cardiomegaly. The pulmonary vasculature is prominent, with cephalization of vessels and indistinctness of the hilar shadows, characteristic of pulmonary edema secondary to volume overload. In the context of AGN, the primary pathophysiology involves an inflammatory process within the glomeruli, most commonly post-streptococcal glomerulonephritis, PSGN, following a group A beta hemolytic streptococcus infection, S. pyogenes. This is a type 3 hypersensitivity reaction characterized by the deposition of IgG, IgM, and C3 immune complexes along the glomerular basement membrane, GBM. The resulting inflammatory response leads to a significant decrease in the glomerular filtration rate, GFR. This reduction in GFR triggers the activation of the renin-angiotensin-aldosterone system, RAAS, though the primary driver of the clinical symptoms is the profound salt and water retention. The subsequent expansion of the extracellular fluid, ECF volume, manifests clinically as hypertension, periorbital edema, and in severe cases, the congestive heart failure and pulmonary edema visualized here. Urinalysis typically reveals smoky or cola-colored urine due to hematuria and dysmorphic red blood cells, RBC casts, which are pathognomonic for glomerular bleeding. Laboratory findings would classically show elevated anti-streptolysin O, AASO, or anti-DNase B titers, and a transient decrease in serum C3 complement levels. While AGN can be a primary renal disease, the simultaneous involvement of the cardiovascular system, as seen here, underscores the systemic impact of fluid dysregulation. Differential diagnoses for this presentation include IgA nephropathy, Buerger disease, which typically presents shortly after an upper respiratory infection, synpharyngitic, whereas PSGN has a latent period of 1 to 3 weeks. Management focuses on supportive care, including sodium and fluid restriction, and loop diuretics like furosemide to address the volume overload and hypertension. Though the prognosis for PSGN in children is generally excellent, with over 95% achieving full recovery, the acute phase requires vigilant monitoring for hypertensive encephalopathy and acute heart failure.